So I have expert colleagues up here. I'm very happy to have everybody up here. And so Kim, would you just introduce yourself and tell us just a little bit about yourself?
Hi, so happy to be here. I'm Kim Thiboldeaux. I'm president and CEO of the Cancer Support Community, and we represent the merger of the Wellness Community and Gildas Club. We have 57 affiliates around the country where we're providing support groups, educational programs, nutrition, and exercise to people with all cancers and their loved ones. We have a research institute in Philadelphia where we do behavioral and psychosocial research, and we have a cancer policy institute in Washington, D.C., and I'm happy to be here, Bill. Thanks.
Terrific, very good. So Michael Kolodziej, who are you and what are you doing here?
Mike Kolodziej, National Medical Director, Oncology Solutions for Aetna. I've been with Aetna now 10 months coming up. I do oncology all day, every day, nothing but oncology. I'm interested in delivery reform. Prior to being hired by Aetna, I worked with US Oncology for 16 years. Till the first of the year, I had an active clinical practice in Albany, New York. I was chairman of the P&T committee for US Oncology for a decade, and I was medical director for US Oncology for about 5 years.
And as you'll see as we continue, we just have people who have worked in a variety of different settings and different constituencies. So, Stan Marks.
I'm Stan Marks. I'm a medical oncologist in Pittsburgh. I'm the chief medical officer and chairman of UPMC Cancer Center, which is a small little cancer center in Pittsburgh. I'm sure you've not heard of. I actually spent half my time seeing patients and the other half being an administrator, which is the less favorable part of my job.
So you have so with your small little cancer center though, you have kind of a small little network. And how many small little oncologists are in this network?
So, well, we have 41 sites of delivery, including medical oncology and radiation therapy. We have about 110 medical oncologists, 30 radiation therapists, and then a large group of surgical oncologists as well.
And you're also an integrated delivery network in the sense you also have a health plan, correct?
Yes, UPMC has their own health insurance product, which is currently at war with Highmark, Blue Cross Blue Shield, and interesting times in Pittsburgh.
Why can't we just all get along, huh? So, Byron?
So I'm Byron Litton. I am with Eli Lilly and Company, and I've been with Lilly and all day long, like Dr. Kolodziej, oncology at Lilly in my capacity. So I've done a little bit of everything from a commercial seat. I've had U.S. And global responsibilities at Lilly. I currently have our responsibilities with U.S. payers, with the group purchasing organizations. I get the luxury of working with advocacy and professional relations partners, and then I head a corporate affairs initiative that sits in our business unit called PACE, or Patient Access to Cancer Care Excellence, where through that mechanism we get a chance to do things like this. So that's my work.
Great. Okay, so we're going to start off with a little scenario here, and we're going to start with you, Michael. So just imagine that actually after the session today, you Twittered out, I never Twitter, but anyway, put something on Twitter, through Twitter, by Twitter, but anyway, got it out there, and you actually were responsible for solving the budget crisis in Washington. And in 3 years, you wake up, and unbeknownst to you, you were actually a write-in candidate for President of the United States, and you won. And your first charge, I think that actually has a semi-high probability, but you
say that knowing me?
Your first charge is to fix the financing and payment methodologies in the cancer care delivery system. That is your mandate as you sit in Washington, okay? And within an 18 to 24-month period, things have to be in place, so it can't be some grand schema or whatever. So just give us a little idea, and we're going to go through the whole panel here, if you will, of what you would do.
This may seem extemporaneous, but thank God I knew this question was coming.
Do you know the lengths we went to keep the secret, but you blew it.
So this is what I would do. I would require that all health information, that all financial transactions in the healthcare system, that everything that lives in the claims database of Aetna and every other payer, that everything that CMS holds, that everything that the individual practices hold be on the same electronic platform, be communicated real time, and be transparent to all the stakeholders. It can be depersonalized, that's okay. I'm all about PHI and stuff like that. But that will allow us to understand who's doing a good job, who's doing a lousy job. It will allow us to define value. It will allow us to make some intelligent decisions about what direction we ought to go. So that's what I would do. I would say, enough of this baloney. I don't care if you're Epic or whatever. We're on the same platform. We communicate real time. That's how we're going to get things done.
And we're going to get things done, but so you're going to basically kind of have specific performance measures, and providers are going to be somehow in, out, preferred, not preferred. I mean, and so you're looking at it from the perspective of you want to make sure that the money that's spent, so you're not going to address that too much, but the money that's spent up front is spent as efficiently as possible in terms of achieving patient outcome. Is that what you're...
That's part of it, but
Yeah.
I also actually believe that the rising tide will raise all ships.
Okay.
So in other words, right now, let's face it, there's really almost no accountability on the quality front. Part of it may be because we can't define quality. But if we can get everybody to understand that they're playing by a certain rule book, heck, it'd be great for the patients, because then they'd be able to behave like true healthcare consumers.
And so, I mean, what do you think? I mean, how would Aetna take a first step in that direction?
Well, we're trying. I mean, we bought a health information exchange, and we're trying to aggregate information. We actually have some really interesting discussions, and people ask me what I like about my job. I get to talk to some really smart people I wouldn't otherwise get to talk to. So there are tools out there that actually are able to structure unstructured data and aggregate that data and report it from the health provider side, from the payer side, aggregate that and get some really interesting information about what's going on.
Okay, one more question, then we're going to move on to Kim. But so, what would be the first step? Because you just said, the hell with Epic and Cerner, and they're all going to use the same platform. How do you get that? I know this isn't your area, but you're the president.
I know where the on button
done?
is on the computer, and that's about the extent of it.
Yeah.
But the truth of the matter is, let's face it, why hasn't this occurred yet? Because there's no business model that makes it Epic's business to do it, right? There's no way they can make money on it. So, government does all kinds of unfunded mandates. This would just be the newest of the unfunded mandates.
Actually, there was a study that showed that it was in primary care, that on the average over a 5-year period, the practices lost $44,000 in terms of implementation of an EHR system in their practices. Just a side comment. So Kim,
Bill,
what would you do?
well, there's a lot of discussion in healthcare and oncology care about putting the patient at the center of care, patient-centric care, and I just don't see it happening. And so if we're talking about how we're going to reform payment, how we're going to improve quality, how we're going to decrease cost, I think we do truly need to put the patient at the center of care. I'm so interested, we're having these conversations about quality, about value, about outcomes. I had to laugh, Bill, some of the pre-reads that we were sent, we talk about this, we talk about a study on pay for performance, right? And it said that while other studies confirm that pay for performance generates improvements in the procedures of care, evidence demonstrating that pay for performance has a positive effect on patient outcomes is lacking. So I said, I wonder what those patient outcomes are that they did in the study. And I read on, and it said there was no significant difference between the mortality rates of those So the outcomes measures that we're looking at are mortality rates in terms of looking at some of these. There's so much more in the patient experience. When I looked at that study, it made me think of that quote, despite continuing increases in the cost of living, it remains wildly popular. Living, that is. And so I think if we can truly get to this idea, not just pay lip service, but truly get to the idea where we put the patient at the center of care, where we talk about what patients want. I mean, why are we still seeing studies where a significant percentage of patients with stage 4 metastatic disease don't understand that they're not getting chemotherapy to cure their disease? There's a simple education and communication solutions with patients when it comes to those types of interventions. Why are we not, when we know that screening patients for distress and providing basic, low-cost, high-touch, high-impact psychosocial interventions help to reduce cost, help patients with adherence to their therapies, yet we are not incorporating and paying for those kinds of interventions in cancer care in America. And when a patient asks, why am I getting treatment A versus treatment B, why aren't they being told? Because treatment A is cheaper, or because somebody negotiated a contract so that now I'm required to give you treatment A before I can give you treatment B, regardless of your genetic profile, regardless of your comorbidities. So if we're truly talking about a model of patient-centered care, and if we truly want to get at a place where we want to improve quality and decrease cost, I believe that if we look at some of these simple solutions and we put the patient at the center of care, understand patient value, that we're going to be able to achieve some of those things, Bill.
Okay, so how do you really think, I have to be like the White House press corps and push back. I mean, how do you really think, though, you're going to get patients to understand, and first of all, how are you going to be able to delineate for anybody, policymakers, never mind just patients, kind of what the interaction is going on in terms of discounts off drugs, step therapy, et cetera, that has preferential drugs that look exactly the same, but there's a discount. I mean, how, and then the second question quickly is, patients, as you know, better than I do, you're an expert, I mean, are sitting there specifically and they're dealing with, a life-threatening event.
Right.
And I think somewhat as the whole cost-sharing thing is a problem, aberration, but anyway.
I hope we're going to talk about
how
that,
are they how are they going to kind of integrate all this into their decision-making?
Well, I think sometimes we underestimate our patients and underestimate their ability to take in information. I think that, particularly in oncology, we have a very educated patient population. And I feel like even in our organization, we do patient education every day at centers across the country. I feel like we have been focused on this sort of 1.0 of patient education. So now, we have sort of the basic curriculum for patients. You need to understand your disease. You need to understand the stage of your disease. You need to get a second opinion. You need to talk to your doctors about goals of therapy. So we've been kind of drilling this 1.0 in. I believe that in patient education in our organization and across cancer care, it's time for the 2.0. And I think that the 2.0 relates to all of these access issues. The 2.0 relates to understanding who your provider is, understanding what decisions are being made, understanding fail-first therapy, understanding step therapy, understanding that if you do have particular comorbidities and the research shows that you shouldn't have that first drug, you should go to that second drug, then we're going to educate patients on how to fight that fight, how to fight that appeal, how to go after the therapy that's right for them. So I think we've done a really good job at the 1.0, but I really do believe with healthcare reform, with the payment reform that we're talking about today, I think it's time for all of us to get to that 2.0 piece with patients. If we give them the information, we give them the education, and we help them to navigate them through this process, that they are going to get to the answers that they need. And I think in this entire conversation, if we put the patient first, put the patient at center of care, and be sure that we provide them with the tools and the resources that they need to get there, I think we can accomplish this, because I think we've been successful in this first phase of educating patients.
All right, and President Kolodziej's platform will lay the groundwork for that, your electronic platform. So, Stan, so you are a thought leader in the community practice. You're the chairman of the board of one of the largest academic cancer centers and networks in the United States, in the world basically. Also, you've been one of the founders of a company that develops pathways and other important information products. So you're now President of the United States. And I did ask the question about the payment and financial aspects, but so what would you do? You've seen it all, right?
Thanks for the build-up, by the way. You can do my eulogy.
Hey,
I think that
I charge by the hour, but that's good too.
I think that obviously our payment system is flawed, and the incentives are perverse. And everything today is driven by volume. More chemotherapy, more surgery, more imaging, and we need to get away from the volume driver and move toward quality. And I think that there are a few things that could start to get us there. You mentioned pathways, and certainly I think we need to standardize care. Being part of Via Oncology, it's been a long road, but we've established under the leadership of Kathy Lokay terrific pathways that standardize care. And it's not just which chemotherapy regimen to give, but it's inclusive of surgery and radiation therapy and supportive agents and palliative care and end-of-life issues and surveillance, and it goes on, because there are tremendous savings in what we spend if we actually focused on some of those areas. But right now, there's no incentive. Physicians are not incentivized to save costs. But if we could develop a reimbursement system that got away from volumes, leave out the drug, forget the drug, keep the drug neutral, so the physicians aren't dependent on drug revenue for income, but rather incentivize them to standardize care, follow pathways, whichever pathways they select or the payer selects, and pay physicians for taking care of patients. We've developed a payment system that actually rewards physicians, in addition to the E&M codes, as well as potentially sharing in the savings. So the physicians are incentivized. Currently, there's no incentive to reduce imaging, reduce hospitalizations, reduce ER visits, improve palliative care, end-of-life issues, where there is so much wasted dollars, that I think that if we could shift gears and incentivize physicians to save money, and they've got to be on board, and they've got to be in a leadership role, and they need to buy in, because physicians are very smart, and they can easily game the system depending on what's developed. So they've got to be at the table, and develop a system where they are actually rewarded for saving costs and improving quality.
So I'm going to come back and challenge you, because I think a major issue is a lot of people put various programs out there, pay for performance, as we'll talk about briefly and shortly. But is there enough money in the system? We always talk about, well, we're all going to share in the savings, and therefore it's going to be able to replace, for example, buy and bill. But we'll come back to that. I think that's an important issue. So Byron, I mean, obviously, biopharma is a huge industry in the United States. Obviously, for patients, it provides innovative therapies, and we're entering quite the age, I think, in terms of whether it's immunotherapy specifically, or whether it's certainly genomic sequencing that helps to direct appropriate therapies to appropriate patients. So what's Eli Lilly, or let me make it broader, what's the industry view, if you will?
Yes, so as I get to go last, hopefully we're not at that place where it's all been said, but not everybody said it. I take it there's a couple of things I'll add to this argument. I think there's a couple of things. If I were to answer the question of getting that presidential nod, I think there are a couple of things I would do. The first thing I would do, I think I would restore ASP plus 6. This is complicated. I think you put an 18 to 24 month time frame on getting whatever we put in place into place. But it's complicated. The infrastructure that's going to be needed to get there is not going to be easy. So I'm not sure, given the convictions I have, my proximity to the oncology community, that an ASP plus 4.3 is right to allow people to languish in that place for the solvency of practices in that interim. I'm not convinced that there's a lot of likelihood that that will take place. The administration has an ASP of 3 in the fiscal year budget. I'm not 100% sure that they think they've seen enough discontinuity in care to do something other than 4.3. And with the additional savings, they think they're going to derive $4.5 billion out of the totality of Medicare Part B over the next 10 years. So that concerns me, one. I think if I were in that seat, that's the first thing that I would get right as we make this transition. I think the second thing I think I'd want us to get right is, I'm very simple about these things. What's the strategy of what you want to accomplish before you get into the structure, before you build it out on the back end? So a lot of what's been said, I absolutely agree with. I think we have to get to oneness on the quality of measurements by which we're being measured. I think whatever we do has to be applicable both the community and the hospital setting. I think that the third thing I think we have to do is amplify the voice of the patient. The patient's voice has to be heard in these payment models. And the last thing is, you're asking for my representativeness of the industry, is whatever we stand up has to allow innovation to flourish. So if you take a look at oncology, medical home, or accountable care organizations, I think as we're leaning into those things, either of those architectures or either that structure would allow for this to happen. Now, I agree with Kim. I think the quality measurements that we're taking a look at now are much more about process, and the experts will say we're starting to squeeze the efficiencies out of that process. We need to get into the back end of patient outcomes and that quality. So I could be a fan of either of those if that structure is set in place. Bundling or episodes of care concern me a lot. I think if you think about quality, I think if you think about applicability to community and the hospital, voice of the patient being first in an episode of care type of payment system, and certainly for innovation. I think doing something more sparsely, more cheaply as the first driver in the strategic structure up under that thing is dangerous for us all. So I think if you've got those basic tenets, those 3 or 4 things that we've talked about, then you build out the structure in and around that, then you're headed in a good place. And I'm not so opposed to having patients in that risk-sharing portion of it. If they know what they need to do and act in a certain way to be able to slow down ER admits or things along those lines, I think an informed patient can play an important role in that setting.
Okay. All good answers. I'm going to come back a little bit, when we get to some of the issues you raise and ask you specifically, okay? So going back to ASP plus 6, I'm going to say, how is that going to make the system more efficient? But I want to kind of get back to the platform and then that issue afterwards. So let's talk about, Kim, both of you actually kind of brought up the issue of, pay for performance in the sense of improving patient outcomes, making patients obviously the center and driving what are appropriate outcomes. But you certainly did in terms of your electronic platform, in terms of, separating different levels of oncologists, clinicians specifically, potentially by being able to measure things. So, is that workable? And it gets at my basic question, is there enough money in the system to incent providers, the provider side, to actually, work really hard and say, okay, I've got to achieve, if it's appropriate, an 87.5% adherence to whether it's VIA or whether it's NCCN, however you want to set it up specifically, and really drive that on an ongoing basis the next year that we're sharing in savings as well. And though we're ratcheting down in terms of what the expectations are, how's it all really going to work? Because I think you've thought about it. How can it work?
So I've learned so much in the last 10 months. People used to think I knew this stuff. I know this stuff.
You got to be on the inside.
And one thing I learned is that, most of the meetings I go to are like with you guys, like a bunch of cancer people. People who are not in this tent, they don't think so much of us. They don't think we're doing such a bang-up job. Seriously. They think we spend a ridiculous amount of money for very limited return. It's the truth. I talk to primary care doctors, and certainly the healthcare executives don't think they're getting much value from oncology. Hell, they hired me. The second thing is this. We should not for a second pretend that the amount of money that's going to be poured into oncology is going to go up. I think that is not the case. And I think that innovation, which I think we need to foster and nourish, will continue, which is to say that if you've got a fixed pot, and that's what healthcare reform really is about. It's about access, yes, but it's also about controlling cost. Mm-hmm. If you got a fixed pot, and you're going to have to pay some money for innovation, where's the rest of the money going to come from for the kind of stuff that we're talking about? And the answer is this, I think. Institute of Medicine says 30% of care is wasteful, it's fraudulent, it's garbage. 30%. What are they talking about? Well, they're talking about the fact that the cardiologist ordered a CAT scan 2 weeks after the oncologist ordered the CAT scan. There's no coordination of care. Mm-hmm. They're talking about people making treatment decisions based on their pocketbook. They're talking about stuff that we can get out of the system. I think everybody in this room could agree we can get out of the system. And that money is going to pay partially for innovation, and part of that money is going to come back to high-performing providers. Now, I hate to say this because I know a lot of you guys work for hospital-based systems, but some of that money is definitely going to come from the hospitals. I mean, and so hospitals are going to need to really start thinking about what it means to succeed in an ACO world, where their sole reason for existence is to make sure every single hospital bed is full. Because that's a winning strategy today. That is not the winning strategy going forward. If you're an ACO, empty hospital beds are your friend, not full hospital beds. So I think there's going to be a redistribution of wealth. There you go. Redistribution of wealth towards high-performing providers. And I think that there's money in the system. Now, do I think that unit cost will need to be approached at some point? In other words, will our pharmaceutical partners be able to just decide whatever the cost of drug is? No, I don't think that can continue. I think there's going to have to be some sort of right sizing. These guys can help us decide what the right sizing should be based on outcomes that are meaningful, right? I think that there may well be new ways to pay for innovation. That is, contracts that are based on quality reporting and achieving certain value-based outcomes. In other words, you don't perform, you don't get paid. Yeah. And I think the pharmaceutical industry has to get comfortable with that. I think that there are models of that happening around the world, and I think it's coming to a system near you.
Okay, so it's just interesting. This is not a criticism of you, but I just remember when I was recruited to Aetna to run national coverage policy in other areas in 1991 from the American Medical Association, we all talked about the fact that 30% of care in the United States was unnecessary or inappropriate. So we're still at the same place. So it'll be interesting to see how we move the dial a little bit. So let me, it popped into my head. So who's going to drive the system now in terms of standing up for patient access outcomes or whatever, standing up for physician autonomy, standing up for innovation, standing up for making sure we have an efficient healthcare system, and they're all blended together. I pointed to individuals individually, as I said, each one, but they're all blended together. So just quick 90-second answers, please. I'm going to start with you, Kim. I mean, are we all going to work together in this all of a sudden? Or is there going to be real advocacy from patient side, clinician side, pharma? So 90-second answers. I mean, who's going to push this? Are we, as Chris Christie just said, I'm going to throw them all in the room and they better come out with something. Is that how we're going to have to do it in the end?
I think that's how we're going to have to do it in the end. As little as there's got to be a Kumbaya moment coming together. And I mean, why did you pick this panel, right? Because we all have a say in this. We all have a stake in this. We all have, our own interest in this conversation. So I think it is. Throwing us all in a room together, and maybe we'll do a little bit of a better job than our Congress is doing now in terms of compromising to get to solution. So so we're not at a standstill in cancer care. But we all have a say in it. We all have an interest in it. We all have a stake in it. Whatever your motivation for doing that, whether you're in it for a profit motive or not. I mean, I'm certainly supportive of a profit motive. I'm supportive of all those pieces, but I think all of us here are going to have to get in a room together, to figure it out. And again, so we're talking about, pathways. We're talking about evidence-based care. We're talking about unit costs. We're talking about patient preferences. I mean, I think all of those things weigh into how we're going to reform a system and get to a place where we can all live. We can all walk away, achieving our goals. Maybe some are going to walk away with a little less than they thought that they wanted to, or thought they would, or intended to, in the beginning. And whoever, I'm not naming names, but whoever that is, maybe folks are going to walk away with a little bit less, including the patient, by the way. And it may be the patient needs to make some choices and make some sacrifices that they would rather not make, or that they thought they would not have to make. But we all have a stake in it, so we all have to come together on the solution. That's what I think.
Okay, so I'm going to ask a preliminary question. Kim kind of stimulated in my head. So what is going to be the signaling moment, and how soon is it going to happen when we're all going to have to get called into the room by President Kolodziej or somebody? And again, I've always said, even when I was with Aetna, I said, it's really hard when, especially physicians, especially oncologists, get together and push hard. It's really hard to resist, what you're pushing for, generally in terms of, again, autonomy, access to care, et cetera. So anyway, but again, if you could kind of respond to both the questions.
Well, I agree. We've all got to get together, and I think it's here. But I think that the main driver should be the providers and the payers, and they've got to put their nose to the grindstone and work together. To your earlier point, where the money is coming from, I think the money is there.
I do too.
There is just so much waste, and if we can reduce the expenditures on some of the things I mentioned earlier, like hospitalizations and chemotherapy in the last 14 days of life, and lack of involvement of palliative care or hospice, ER visits, and using high-cost drugs that have very little benefit to the patient. Nothing against my pharmaceutical friends, but there are agents out there that are $10,000 a month, that add very little with no survival benefit. We've got to rethink about using those types of drugs. And I believe there is sufficient money there. To Mike's earlier point, I think the number is probably right. There's at least 30%.
Oh, it's been measured over and over and over again.
And so if we restructure this and get away from driving volume and focus more on quality and standardizing care and pathways. I'm not a bundling fan. I don't think bundling works in oncology, especially if the drug's included, because the docs cannot take the risk. There are price increases that they can't handle. It takes 6 months to a year for that to change. There are changing indications for drugs, whether it's maintenance or continue through progression or expanding role. The drugs cannot be part of the bundle because there's too much risk to the physician. And I think you got to get the drugs out of the equation. Physicians should not be incentivized to give more drug to improve their income.
Okay, great. So Byron, so in terms of, who's, actually, let me just ask you, since you said the time is now, who's going to call the question? If the time's now, who's going to call it up here? When are we going into that room? See, who's going to call the question? Because it's not really now. It's coming. The apocalypse, is coming, but.
When? So I think the thing that precipitates us coming together, and I'll say, by the way, as I've been in this capacity for the past couple of years, I've been really surprised, and Christian and I were talking about this earlier, I've been surprised at the level of collaboration. We've sat down with Aetna, the discussions I've had with the GPOs have changed over time. I think the proximity and the rightness of the relationship with the advocacy organizations is different than I think a lot of people in society would understand. So I think we're getting there. I think we have to hurdle ourselves toward it. And I think what will do that is, and I saw the audience reaction, it's going to be hard for people to come together. But I think that fear is a motivator. I fear that I'm going to have to walk back out of a business decision around a tumor moving forward, which we'll not be able to invest in. We'll have to walk away from it and forever think, would we have been able to do something for that community? Kim fears that patients are going to be lost in the system. We're going to have another generation that will not get top-level care. Dr. Kolodziej, Dr. Marks, the physician autonomy is going to be gone. We're not going to be able to do the things to be able to advance cancer as we should, to make this a chronic disease. Here's the fear that should motivate us. If we don't intercede in the free market space, we're going to see a president step in and institute mandates. And this is a story that I often tell, but it's a story worth repeating. If a woman in the UK has breast cancer and she has stage 1 disease, she has a 78% chance of 5-year survival. In the United States, if a woman has stage 1 disease, her chance of 5-year survival is 97%. So we have to do something that allows us for our daughters and granddaughters to be able to continue to not only in early stage disease, not only in breast cancer, but deliver the best care in the world to the broadest population possible. If we move into a situation where we see mandates, governmental mandates that are arbitrarily set, we're going to see a reduction in the ability to innovate. We're going to see a reduction in the ability to deliver care. And we have to get that right before it comes to us in a mandate. I think that the awareness of that should precipitate us to move faster.
Yep. And we're going to touch on risk sharing between pharma and insurance industry, but on my back I have a few scars because, I took that 30% number in the 90s when I was at Aetna, and I took it in orthopedic surgery. And there were studies out there that showed that basically the addition of continuous passive motion machines to, so just think of the level, that versus life-threatening disease like cancer. Continuous passive motion machines didn't add anything to physical therapy, so we basically said it's either physical therapy or CPMs. 3 days after Aetna issued that policy, the medical director for the Western region from San Diego said, Bill, we have World War III going on out here with the orthopedic surgeons. So, as I say, that's why that 30% number is still there. It's a tough issue. Okay, so I'm sitting there and I'm like the other party's candidate, and I'm getting ready for the debates 4 years, because I'm sure they're all preparing for debates in 4 years, and I'm saying, that guy, whatever his name was, the bald guy, fat guy up on the stage, basically asked a question, and I don't know that anybody ever answered it. So tell me, financially, how this is actually going to, work. So let's jump into it. So we've talked a little bit about bundled payments or episode-based payments. Is that what's the solution? I mean, is that the way we're going to end up going, Michael?
I think so.
Okay.
So
we already have kind of
so let's
not
go,
tension, but anyway,
let's go
a way to figure it out.
Let's go back a step. Right?
Okay.
So we have a general agreement that the current fee-for-service system, which rewards volume versus value, is a broken system. Okay, that's easy to agree upon. So we're talking about migrating from that system to a system in which there's both upside and downside risk for the provider. Problem with the provider contemplating a world where they have both upside and downside risk today is they don't have all the information that allows them to be able to accept that risk, nor do they feel confident that they have the operational capacity to influence that risk. So the first step is to try to provide them, to arm sophisticated practices with the information. And the second thing is to help them define the operational capacity, operational skills that are needed to succeed in the system. And so that's where pay for performance comes in, because what pay for performance is, for all intents and purposes, is upside risk, right? So you implement a system where you reward practices, physicians for good behavior, pathways compliance, keeping people out of the ER, keeping people out of the hospital, doing advanced care planning, all that kind of stuff. You reward them for giving the patient good quality care as defined by the current methodology. And then all of a sudden the practice starts understanding that if they have a 75-year-old woman who's going to get adjuvant chemotherapy for breast cancer, that's very different than treating a 35-year-old woman. And maybe they got to make a few extra phone calls. Maybe they realize that at 3 o'clock on a Friday afternoon, you don't start thinking about happy hour. You start thinking about whether or not that person who called 5 minutes ago needs to hightail it in here because they have a fever of 99.8 and you don't know what their white count is. So we're talking about some changes in the operations of the practice. Honestly, a sophisticated practice knows that in their heart of hearts. They know that's what they've got to do. They just got to enforce it. They got to do it. Now, what happens when you have a good understanding of how your practice works, what's happening to your patients, then you've got a situation where you can say, wow, if I go this extra step, I can actually do even better. Also keep in mind that I don't think, there's appetite and there's aptitude. A lot of appetite now, not too much aptitude, right? So we need to get to a world where practices can marry appetite and aptitude. And there's going to be winners and losers, guys. Not everybody's going to get a medal at the end of this competition. Some people are going to get medals and trophies, and some people ain't going to be so good about that. And I think ultimately a practice will get comfortable. Also keep in mind that if, in fact, we go into an ACO or an integrated delivery system type model, that type of behavior will be expected of the oncologist as they play with the ACO.
I can see it there, but I need a 30-second answer. So John Sprandio is the epitome of the patient-centered medical home, saving millions and almost going bankrupt because hiring extra people to call the patient at 4:30 in the afternoon, et cetera, and start of the day. And I know you may have a pilot project and I know you just got there basically. So, but
I've only been working 9 months, Bill.
Right. Well, hey, women can basically deliver a great product within 9 months.
They're not giving birth to oncologists. So.
Well done, Bill.
So come on. Maybe put the women in charge, right, everybody? All right.
Woo!
But anyway.
Girl power.
But actually, you kind of disrupted my
Your flow?
Isn't that the idea?
Yeah, no, but I mean, so he's had a heck of a time getting to get arrangements where he gets, reimbursed at an increased level for clearly demonstrated savings. So 30 seconds, then I want to move on.
It's
So
a
sorry.
slinky, right? So what is happening now is very, very different than what was 2 years ago. I gave a talk, ACCC, 2 years ago, still working for US Oncology about pathways, and it was Nowheresville.
Yeah.
But it's gone to the front. I'm in the process of negotiating a multi-practice pilot around patient-centered medical health.
Great, cool, good stuff. So Stan, how do you react to that? I mean, you've got over 100 oncologists, radiation oncologists, et cetera. So you've got your pathways, so you can estimate resource consumption probably much better than other people. But how are you going to react to a world where we have episode-based or bundled payments, or more global payments in general?
Well, I think that we're prepared for it. I think that, I think we're ahead of a lot of other centers, but realistically, our physicians have bought into the concept. They understand the importance of, getting away from drug margins and focusing more, and away from volume and focusing more on quality. We have efforts underway focusing on getting palliative care involved sooner. We're monitoring our hospitalization rate, and we've actually been able to demonstrate that with our pathways, we've reduced hospitalizations by about 15% compared to practices in our region that aren't on pathways. And that's huge savings. I mean, again, as you know, the hospital is one of the highest cost components of cancer care. So, we're ready for it. And UPMC has their own health plan, so obviously we've sat with them and worked on this. With some of our other payers, we're not quite there yet, but I think that we're in pretty good shape.
Okay, so I see I'm bringing everybody closer together here. This is cool.
Kumbaya.
Start to think of questions or issues you might want to raise, okay? So,
Wanna comment on this
yeah, I'm
bundle?
going right to
Good,
you.
thank you.
Yeah, so just give us your comment.
Thanks, Bill. I think that with regard to bundle payments, I think the upside for the patient is that it is going to motivate practices towards more comprehensive care planning, because we're going to think about ways to take care of the patient throughout care. We're going to look at some of these and integrate some of these high-touch, low-cost interventions, psychosocial interventions, distress screening for cancer patients, and we're going to do, I think it motivates practices to do a better job of taking care of the patient throughout the continuum of care. I think the risk and the downside is, and the thing that concerns us from our patient standpoint, is the cost-sharing burden or risk for the patient to take, especially as you were saying, Stan, as it relates to the drug cost. I think that is the biggest risk for the patient when it comes to the bundle, is that a patient could get a second choice or a third choice therapy, and that the practice and the physician are not going to be as motivated to give the first choice therapy that they want because it's going to be cost prohibitive, and they're trying to stay within the parameters of those of the bundle. Stan and I were having a really interesting conversation at lunch, because I'm really interested in this, in that the Dr. Weeks study that was out in the New England Journal last year, 1,200 patients who had stage 4 metastatic disease, lung and colorectal cancer patients, and 65 to 70% of these patients did not know that they were not getting more chemotherapy because to cure their cancer. They thought that they were still getting chemotherapy to cure their cancer, stage 4 metastatic patients. And we were saying, why is that? Well, number one, the physician doesn't want to say it, that I can't cure your illness, or the physician says, you have stage 4 metastatic disease, and the patient says, okay, now what do we do? They don't understand what that means. The patient doesn't want to give up. They're scared to give up on themselves or on their family. And the last thing is, there is this interesting, we talk about the importance of the integration of palliative care. The integration of palliative care has to be integrative palliative care. It can't be, there's nothing else I can do for you, so let me send you down the hall to the palliative guys. And the patient's going, wait a minute, I've been with you for all this time. Now are you giving up on me? And suddenly I'm going to the palliative care department, and I don't know who. So there's this sort of abandonment issue that also comes with that. Yeah. I think with some simple education, I think that patients really would choose to stop therapy in late stage disease a lot sooner than they are. So this is what I mean when I say we have to invest in these high-touch, low-cost interventions. We have to invest in them. Look, when you talk about value, we pay for what we value. And if we say that we value patient-centered care, and if we say that we value psychosocial care, then we have to start paying for care. We have to start, thank you. You know, we have to start, you know, I mean, you know, we want to study some of these interventions, and there's hundreds of millions, billions of dollars that continues to be poured into studying more drugs and more biomedical interventions, which we certainly support. But I'm sure many of you, particularly those in behavioral care, I mean, I have a half a dozen studies right now in psychosocial oncology that I can't get funded. And so if we say we value these things, we have to put the money behind it, both to study the effectiveness and the cost effectiveness of these interventions, right? Because I believe that by managing patients' distress and anxiety and helping to navigate them through their care, it's going to lead to cost savings. So we have to invest in those studies, and we have to invest in and reimburse for the integration of those services into care.
Okay, actually have a coalition forming here. So let me ask Byron, in terms of, again, potential impact of more global payments,
Yep.
episode-based payments on innovation. I mean, you know, what the average, you know, it's in the literature, $1.5 billion to bring a drug to market. That includes drug failures along the way. But anyway,
Yeah.
so what's this do for your investments?
Yeah, so we will see in industry, we're going to see price pressure. There's no doubt about that. We have that coming to us in a cost containment era. As we see, the numbers are at 2030, we're going to see 45% more diagnosed cancer patients. So we have this incredible challenge that we're in the middle of. So we're going to see pricing pressures. There's no doubt about that. So I think some fundamental things. Are drugs expensive? Yes. Why are drugs expensive? And I don't know that collective community, even in oncology, can explain that. And I think this is one of those pieces where we can work together better. Look, at the height of the HIV scare, it took 24 months from discovery to get AZT on the market. So there was a rush, there was an opportunity there that we stepped into. And in difficult to treat tumors, it takes us 9 to 10 years to develop a drug. And as we go into smaller and smaller patient populations, that becomes more difficult. That those timelines expand. The business model doesn't work. And I think if you ask the question, why are drugs expensive, and you connect that back to profitability in the industry right now, those things don't match. Take a look at stock prices, take a look at the announcement on job sizing within the industry. Something doesn't mix there, and the assignment being that industry is greedy. The current path that we have to get a drug on the market, particularly in difficult to treat tumors in small populations, doesn't work. That's the foundation of the entire discussion that we're having here. So I ran business cases previously. We'd run net present value. The front end of net present value in a business case to bring a drug to the market is all, how long does it take you to develop a drug on your clock to patent expiration, which starts way early, and then how much are you spending in that investment? We are spending more than $1 billion on each drug. And the number, Bill, just to correct you a bit if I can, on the drugs that fail, when you assign all that R&D on the drugs that can make it out, Forbes had an article out in August that said on average, the industry is spending $5 billion for every new product that comes out. Only one drug in 20 that goes into human testing makes it. So that's all broken. That's my fear. That's what brings me to the table to say we've got to find compromise. We've got to find compromise in the way that we appropriately price our drugs moving forward. So I think that's important. There's a bit of optimism that I do want to share here. We're just now moving into an era where we actually have competitiveness. In tumors, stages of disease, and lines of therapy, you might actually now have 2 or 3 options. And that's the best form of price containment. In the 16-17 timeframe, we'll see a wave of generics come along on some of the more expensive drugs that I think will help. So we own that responsibility to do the right thing on pricing. I think we'll see risk sharing coming out in a short order, particularly if we'd fall out of an ASP environment. Michael and I can't sit down at the table right now and say, we want to do some risk sharing in and around one of our assets, because that affects ASP. It would put anybody who didn't have that underwater, and so we can't get there. But I think we're going to see pricing pressures. I think that we need to prepare for that. We need to link ourselves back to being able to say, our molecule affects quality in this way, and this substantiates the price. That's that firm footing that we need. We're in for that. Lilly is in for that. And I think that's where we're headed.
Well, I think that HIV example is a great one, because I'm not much for committees. But you know, if I were elected president, basically the first thing I would do is set up a committee of people that say exactly what they think, to take a look at the efficiencies and inefficiencies in the whole clinical trial system in the United States, and the processes as they relate flowing right through the FDA and right through up to CMS to integrate it. Because I think, you know, long term, these longitudinal observational databases in phase 4 are going to expedite expansion of our knowledge and indications, et cetera, et cetera. But so that's I wanted to play the game too. Anyway,
Can I just say one thing?
Yes,
quickly.
please.
So, and I think from our perspective, you know, I don't think there's a right price. There's not a right price for a drug. You know, and drug pricing is challenging. There's not a right price for a drug, but there's a wrong price for a drug. The wrong price for a drug is if the patient can't get it and can't afford it. The wrong price for a drug is if the physician won't prescribe it. The wrong price for a drug is if the payer won't pay for it. And the wrong price for a drug is if the company can't continue to invest and innovate. And I know it's a delicate balance to find that, but I think we have to weigh all those factors in and expand and collaborate on that pricing conversation. Byron.
Absolutely.
Yeah.
yes. So again, it's time for questions. We already have one. That's great. So if others would like to approach the microphone, that'd be terrific. So yes.
Stan, it's 3 o'clock Friday afternoon. Patient calls. They have 100-degree temperature. You own the health plan. How does your health plan presently incent your physician provider to say, come on in, let me get a CBC on you right now, get you started on antibiotics if necessary, versus, well, it's 101 degrees or it's 100 degrees, go to the ER?
Well, the health plan right now is not incentivizing us to do that, but you know, we, as you clearly point out, the preference is to have that patient come to the office. And this is one of the issues that I have, frankly, with bundling. Because if you bundle, for example, E&M codes, there's no incentive for me to stay in the office and see that patient. Go to the ER because, you know, you come to the office, there's no benefit to me. It's not my, I'm going home. And so I think there's a risk, that's the other risk with bundling, is when you bundle E&M codes, you disincentivize the physician to keep patients out of the ER or the hospital, and that's a perfect example. If I'm getting paid, then I'll have that patient come in, and if I'm being incentivized not to admit patients, a patient will be in my office and get the CBC, and I'll decide whether they need hospitalization or not. So I think there are a lot of inherent risks with bundling, aside from the drug piece that I mentioned, and including E&M codes is certainly a problem. I think there's one area in oncology where bundling makes sense, at least from my perspective, and that's radiation therapy, because it's a finite treatment. It's not changing all the time.
It's a procedure.
It's a procedure. You can combine the E&M or the professional and technical fees. And in this day and age of increasing hypofractionation, it certainly makes sense for my radiation colleagues. But I think that piece of cancer care, it makes sense to bundle.
Oh, follow-up
Yeah.
question. How would Aetna incent the doctors to do the right thing, which is, come on in, let me see you. I think my benefit is, if I see you now, I don't get the call Saturday morning to come in. You've been admitted. I don't want to go in on Saturday. But how does Aetna incentivize?
So we don't yet, but I have a way to do it. So let's be honest. I'm well aware of the fact that ACCC has a lot of hospital-based providers, often in an employment arrangement. There is no incentive for a hospital-based provider to do that. There's none. Now there may be, as I said, if you get to an ACO world,
Yes.
but in the current world there is zero, none. So I'm going to tackle hospital-based providers next year. I'm working on community providers this year. If you are a community provider, see, so here's the problem, right? When people think about bundle, they just think about drug. That is not the way to execute a successful bundle. In my mind, and again, I'm thinking a lot about this and how to build it out. The way to execute a successful bundle is to establish a management fee based on some fair average margin around chemotherapy. Pay drug at cost, give the management fee for that. I will challenge you, Stan, that with the way we do things when we bring people to the office all the time just to hold their hand and say how they're doing, may have psychosocial benefits, but I'm not sure you can prove to me that other than it's the way that we've always done it, that that's the right way to do it. So how do you incentivize the ER visits? You have a modifier for the bundle that rewards you for performing better than your in-market competition. And your bundle is plastic, and it depends on your performance on radiology evidence, laboratory evidence, ER and hospitalizations. Your bundle will change maybe from quarter to quarter, maybe from year to year, and you will be incentivized to perform because your bundle will be better. You will therefore do better. Also, your bundle will be impacted by performance of quality metrics. In fact, you will not participate in that gain share if you do not meet the quality metrics. You're out, baby. That's how I think it works.
Okay, so it may be closer than we think. Question or comment over there? Could you please introduce yourself and your affiliation for the audience?
Cecilia Zapata, Seattle Cancer Care Alliance. I think you've touched on this issue, but perhaps elaborate more on what are the risks for patients to know more or be aware of during the changes in payment systems.
Kim? Can you repeat a little lot? Yeah.
What are the risks?
Yeah.
What
What
risks
should they be aware of?
that patients need to be aware of in time of these changes in payment systems?
Well, I think that they certainly need to be aware of their own out-of-pocket costs. I mean, we're still, we're still at a place now where 54% of all personal bankruptcies in the United States are as a result of healthcare costs. And a significant number of those people actually had health insurance, which is kind of a scary proposition. So I think as the reforms take place, certainly I think the main thing that patients need to be aware about is their own personal risk as it relates to copays, as it relates to deductibles, as it relates to out-of-pocket costs. And it'll be interesting. We're all at this place where we're seeing the Affordable Care Act being put into place in the state exchanges, and there are a number of out-of-pocket protective measures for patients in the Affordable Care Act. There are rebates for patients depending upon their income. I think it'll be interesting to study this model of the implementation of the Affordable Care Act to see how well those protections that have been built into the ACA work for patients who are buying coverage through the exchanges, and are there things that we can learn from that as we look at reform for patients who are not buying coverage through the exchanges? What can we learn about those protections? Are they working? Are they not working? What's the real impact? What's the real impact on patients? Because I do think that there will be lessons learned that we can provide to those patients who are in private pay. But as we look at reform, I think one of the most significant issues we're going to have to look at, for patients, aside from choices, aside from patients understanding step therapy, understanding fail first, understanding, asking the question, why was I prescribed this therapy? Because I think we coddle patients a little too much. I think that if a patient understands that there's a pathway in place and you're getting this drug because this is what your insurance company will pay for, or this is what has been decided in the system, you need to try first, and if it fails, we're going to go to this. Patients have the right and the capacity and the wherewithal to understand that. So to me, as this reform happens, there just needs to be full transparency with the patient across the system, and then let the patient make some choices and let the patient decide what trade-offs they're willing to make with regard to their treatment path, and not be so sort of paternalistic when it comes to these choices.
Did you have a comment, Byron? We're going to have to end, but who wants?
No,
Dan, okay.
No, I just wanted Kim to tell the group what her organization does in terms of providing for patients we discussed earlier.
Yeah, so we have 57 centers around the country. We provide free, everything's free. It's all through private fundraising. Support groups, educational programs, nutrition, exercise, stress reduction for people with all cancers at all stages of their illness, and for the family members and loved ones of people with cancer. We have a helpline. We are actually the largest nonprofit employer of psychosocial oncology mental health professionals in the country, oncology social workers, psychologists, master's family therapists. We have a helpline. You can send your patients to our helpline. We have an online community, online support groups. We have a research institute, and we have a policy institute. So I appreciate you.
And what you've put together for questions that they need to ask.
Oh yeah, as it relates to the Affordable Care Act, this is important, Stan. Thank you for reminding me. But last week we issued a cancer insurance checklist. And if you have patients who are looking to shop for coverage, patients with cancer who are looking to shop for coverage through the exchanges, on our website, cancersupportcommunity.org, is a checklist that your patients can use as they're shopping for coverage through the exchange, so they know what questions to ask. I think patients don't know what they don't know as they're getting into this exchange business. It's a checklist to say, is my doctor, will my doctor be covered if I buy this plan? Are they in network? Are they out of network? What does that mean for out-of-pocket costs? What about breast reconstruction? What about genetic testing? What about fertility preservation? These are all of the kinds of questions that patients need to ask if they have cancer and they're shopping in the exchanges. So that checklist is on our website. It's available to all of you, and I hope that you will make it available as a resource to your patients.
All right, I'm a time nerd and we're already over, but if you can ask or make your comment in 30 seconds and I'll get a 30-second response up here.
I will.
You get the last say, so to speak.
My name is Faye Satterley. I'm from Martha Jefferson Hospital in Charlottesville, Virginia. I'm the director of that area, and it's a not-for-profit hospital. I've been in hospital leadership for about 25 years, and I know that our profit margin has been between 1.6% and 8%. But what I've heard mostly is the emphasis on hospital and physician waste, and I wonder about profit margins in the other organizations that feed into healthcare, which I also think contribute greatly to any waste.
Wow. You know, I think what you've done, the way I'm going to handle this is you've identified maybe the subject for the next session. No, it's a superb question, but I mean, for us to even tackle it in 30 minutes, never mind 30 seconds. So, I did say you did have the last say, though. So, what I would like to do, though, is certainly thank Eli Lilly for their support of this event. Certainly, it's an ACCC event. We're extremely happy to have had it here in my hometown, 307 first pitch, Red Sox, but who's tracking that? But it's been a great session, and most importantly, I want to thank the panelists who are just great, honest, direct, straightforward.